Start my video as well.
Okay, hi everyone, thank you for joining us today. Today's tutorial is on Paediatric Gastroenterology given by Dr. Hayward. Just a few rules. If you're watching on the Zoom, any questions that can wait till the end, pop it into the Q&A. Any questions that are relevant to what's being covered in the tutorial in the moment, just pop it into the chat. That's all from me, and I'll hand over to Dr. Hayward now. Thank you. Sorry for
the slight delay starting. We had some technical issues. My name's Ben. I just finished medical school at Imperial, and I'm currently doing foundation interim placement. I really like pediatrics. It's something I'm very interested in and I've read a lot about, and so hopefully I will be a good source of information for you guys. Tutorial will last a little bit over an hour. I wanted to include lots of good stuff for you guys. And I think some of the stuff I've chosen is quite difficult. So don't stress if you can't get some of the questions or things like that. I just wanted to kind of push you all and sort of get you to think a bit sort of differently about it. So this is just a disclaimer. This obviously doesn't replace any of your core teaching. And what we're going to aim to do by the end of the session is firstly be able to produce an extensive list of GI and non-GI causes of vomiting in a neonate, an infant, and a child. We're then going to be able to recognize red flags in a child who presents with vomiting, and then we're going to understand the medical and the surgical management of some of these common and serious conditions. So this is going to be the vague sort of plan. We're going to start with the general approach to vomiting. We will then move on to 3 cases. The first one is going to be a medical emergency, the second one a surgical emergency, and the third one vomiting in a neonate specifically. And then finally, to finish off, we'll do a quick review of everything and we'll have some more questions. I think if you have any questions at any point, just ask them in the chat. And I think after each section, we can sort of go through them and make sure you guys are all happy before moving on. So, in terms of an approach to vomiting, to start off with, I want you guys to just spend a little bit of time coming up with a list of sort of causes of vomiting and thinking about how you can divide it. So you could divide it based on anatomy, you could divide it based on doing like a surgical sieve, you could divide it based on age. So just spend a little bit of time thinking about that, thinking how you could divide up your causes, and then I'll show you how I've done it. And then while you're doing that, try and think of what some of the sort of key questions are to ask in a child who's vomiting. Maybe like 5 questions, how you can differentiate the different types. And then also try and think of some of the red flags, so things we really want to look out for that indicate a child might be unwell. I'll give you a little bit of time to do that. And of course, this might be something good to do in your own time as well. So the way I've done it is divided it into GI and non-GI causes, and then I've divided it by age group as well. Obviously, there's lots of overlap, so neonatal causes can present late sometimes, and so on. If we look at the neonate first, we'll start with the GI causes. So the most sort of common condition is probably GORD. They present with this with gurgit and vomit. In addition to the regurgitation vomit, you've got your more bilious vomit. And when people say bilious vomit, that should spark like a red flag in your head, because that means there's some kind of intestinal obstruction going on. In the neonate, that intestinal obstruction is most likely to be duodenal atresia. So that's an absence or of the duodenum or part of the duodenum, and that's associated with Downs. And then also you've got your causes of obstruction a bit lower down in the GI tract, and they'll also present with a distended abdomen. So in the neonate, we're thinking neck, we're thinking Hirschsprung's, meconium pileus. and then also some non-GI causes. So don't forget your infectious causes. UTIs, for example, can present really strangely in children, as can meningitis and sepsis. And remember, we have that traffic light system, children with a fever, so we're always very sort of on alert for children who present with a fever or vomiting, so never forget sort of infection and meningitis and things like that. Moving to sort of infant, so it's slightly different here. It's less sort of these early congenital causes like duodenal atresia and Hirschsprungs. In terms of your regurgitant vomit, you get things like GORD. You can inhale a foreign, swallow a foreign body, certain food intolerances like lactose intolerance, infections, and also certain feeding problems. So, for example, if mum's breastfeeding, and the nipple can become quite dry and irritated, the baby might be, in addition to milk taking in blood, which can irritate the stomach and lead to them vomiting. And then we've got some sort of other types of vomiting, so projectile vomiting, that makes us think of pyloric stenosis, and then kind of bilious vomiting. Again, bilious is obstruction, and then this sort of age group, we're thinking malrotation, intussusception. And then again, there's some non-GI causes. And in sort of children and adolescents, we're again thinking similar causes to adults, things like gastroenteritis, surgical causes like appendicitis, then also your medical ones, so DKA, psych, pregnancy, even in older children. Okay, good. So in terms of what kind of questions you think could help differentiate them, does anyone have any sort of ideas? You can just sort of pop them in the chat as to sort of a really good question you could ask when taking a history to sort of help differentiate the causes. We just got a question on the Q&A thing as well. So I'd say a neonate, it depends on at what age they were born, firstly. So if they were born at 25 weeks, you'd usually sort of say sort of 4 weeks post when their due date was, if that makes sense. So they'd been in it for a long time if they were born premature, but about sort of 4 weeks. Of course, these are all just terms we've made up, and it's all a spectrum. And as I say, you know, a condition that normally affects a neonate like Hirschsprung's can affect an older child as well. So yeah, any sort of ideas or questions? So important questions I think to ask are firstly, when did the vomiting start? So that can help us differentiate more sort of acute causes. So is this something like obstruction, or is this more of a chronic thing like GORD? Sort of the nature of the vomit as well. So is it bilious? Is it non-bilious? We want to know about changes to the stool. So is there blood in the stool? Are they not passing any stool? That can all go with obstruction again. And then things like how they're behaving. So have they been more lethargic? Are they more tired? Do they have sort of signs of dehydration? Okay. And then in terms of risk flags, what any sort of ideas what those could be? Sort of have a think about maybe like 5 red flags to sort of be aware of. So I would say in terms of red flags would firstly be bilious vomiting, as I've said a few times. So that goes with obstruction. In addition to that, also abdominal distension, again thinking obstruction. A fever, so we're thinking infection. If it's projectile, you're thinking pyloric stenosis. If they're in severe abdominal pain, you might be thinking appendicitis, or again, something like they've got volvulus or something like that. And then are they dehydrated? So have they been having less wet nappies and they've got a fast heart rate? Okay, good. So that's sort of a general approach to vomiting. I think what I learned is as you got older, you don't necessarily need to know the cause all the time of what's going on. but you need to be aware of, is this sort of serious or is this not serious? And that's why sort of knowing those red flags is really important. Okay, so we'll go on to our first case. So this is a medical emergency. I'll just read the case for you. So Harry is a 9-week-old boy, and he presents to Peds A&E with his mum and dad. And we've asked all those really key questions that we talked about. So what the timing is, been about a week, and he vomits after meals. The quality of the vomit, what's it like? It's not green, there's no blood in it, it just looks like undigested milk. What's the sort of forcefulness of the vomit? So the mum said it's quite forceful. How the baby's behaving, so still quite hungry after feeds, but over the last few days he's been less hungry. He's also had some less frequent stools and wet nappies. He's just been a bit more drowsy as well. So normal anatomy, postnatal history, and then on examination they're tachycardic, they've got a prolonged bill, and they have reduced skin turgor as well. So in terms of differentials, have a think about what it could be, bearing in mind the structure we've come up with, so the age group and your GI and non-GI causes, and try and have a think, does this child have any sort of red flags? I'll just give you a little bit of time to think about that. So someone on the chat asked, how do you know if an infant is in pain? That's a really good question, and I think it's really hard to tell in reality. We'll go through some of the presentations later, but as you said, crying, and often it's different to their normal crying, and that's why you really need to listen to parents. So the crying, they'll say there's a difference. They'll know, they might not be able to describe it well, but they'll know there's sort of a change in their behavior. So listening to the parents is really important. And then also things like they sometimes draw up their legs to their tummy, and the crying will just sort of be incessant. So that's kind of how you would suppose they're in pain. So in terms of so GI causes, things like pyloric stenosis, GORD, calcium protein allergy, and then non-GI, so it could be something like a UTI. They can present quite strangely. Okay, so we're going to do our first question now. So given the likely diagnosis, so we've sorted some differentials, but what's the most likely one? What do you think the underlying pathology is? So I'm not sure if we've got the polls working, we might not have done, but if not, just try and have a think, and just write it down, think what you put. So is it failure of the pyloric sphincter to relax? Is it an immature gastroesophageal sphincter? Is it hypertrophy and hyperplasia of the muscle of the pyloric antrum? Is it absence of bowel and myasthenic plexus in a portion of the bowel wall? Or is it the absence of the duodenum? So just give you a bit of time to sort of think about it, and then we'll go through the answer. So, correct answer is C. So this is classic pyloric stenosis. Pyloric stenosis normally presents at about 6 to 8 weeks, and it's due to hypertrophy of this area of the stomach, the pyloric antrum. It's not the pyloric sphincter, which is over here, it's the pyloric antrum. And what it means is that none of the stomach contents can get out of the stomach. They all build up in the stomach, and they forcefully are ejected from the stomach and need to projectile vomiting. The presentation leads to certain signs we see on examination. So when the baby is not being fed, sometimes we can feel a olive-like mass on the tummy, and that's just this hypertrophy antrum, pyloric antrum. And sometimes we can see the waves of peristalsis of the stomach, trying to work really, really hard against the obstruction. to the degree in which we can actually see it. Going through the other options, the first one's not really a thing. The second one describes GORD, which isn't really the case here because it's a projectile vomiting. D describes Hirschsprung's disease. So in there, you'd again maybe be a little bit younger. You might have constipation, and you might have abdominal distension and bilious vomiting. And then the first one would be duodenal atresia. Okay. Good. So let's move on from there unless there's any questions at all. So you decide to do a blood gas, and I just want you to look at this and have a think about what this would be, and then we'll go through it together in a second. So just try and interpret it. Just to the side note for Paediatrics, we often take capillary gases instead of like an ABG or a VBG. This is just because it's easier, it's a lot less painful than having an ABG. It does mean we can't necessarily interpret the AO2 and the PCO2 as well, but that's just what they do in practice. So going through the gas, we start with pH. So the pH is high. So that means we've got low hydrogen ions, we've got alkalosis, and we need to know, is this respiratory or is this metabolic? So the PCO2 is normal, so it's not low, which you find in respiratory, and the bicarb is high, so that fits in with a metabolic alkalosis. And then we need to look at these electrolyte abnormalities as well. So our sodium's low, our potassium's low, and our chloride is low. So we call this a hypochloremic metabolic alkalosis. Now, something I didn't really understand when I think I was in 5th year is that these electrolyte abnormalities are really, really serious. They are what cause sort of the serious complications of pyloric stenosis, not the necessarily the inability to feed straight away, although of course it would do in the long term, but it's these metabolic abnormalities. And the fact that hypochloremic is significant. I never really understood why it being a hypochloremic metabolic alkalosis, other than another kind of metabolic alkalosis, was important. And it's because that hypochloremia, the low chloride, helps to perpetuate and maintain that metabolic alkalosis. And so it worsens the situation. So I'm going to spend a little bit of time just explaining how we get these metabolic abnormalities and how those lead to the maintenance of this alkalotic state. I think this is a bit above what they'd ask in your exams, but I know lots of you have path and stuff, so I thought it'd be good to go over. And for me personally, I like to understand why things are, so I think it's quite useful. We'll just go very quickly. So you have a child who's vomiting. They're going to lose lots of hydrogen ions, and they're also going to retain bicarbonate, because obviously normally after the stomach, the contents would go to the duodenum, and the S cells would release secretin, and that would lead to a release of bicarbonate with all the exocrine juices. And that's not happening because nothing's getting to the duodenum, and so we're not getting that secretion of bicarb, and so we're retaining it. And that means we get an alkalosis. In addition to this, we're also losing lots and lots of fluid, and that's going to be detected as a low blood pressure in the glomerulus of the kidneys. And so we're going to get activation of the renin-angiotensin system, and so we're going to get lots of aldosterone. And aldosterone is going to lead to the activation of those transporters in the nephrons, if you can remember them. So you get sodium exchange, another transporter, which exchanges sodium for hydrogen ions. So because we've got a loss of fluid, and thus we get high aldosterone, we get exchange of sodium for potassium, which causes hypokalemia, and we also get sodium exchange for hydrogen ions, which again worsens your alkalosis. Okay? I know it's quite complex, but I think it's important. In addition, when you're vomiting, you're going to lose lots of chloride. There's some cells in the kidneys called the intercalated cells, and they are important for acid-base balance. And because our chloride's low, we can't do the normal body response in alkalosis of excreting bicarbonate. We can't do it. So we get retention of bicarbonate and thus an acidic urine. And again, that worsens your alkalosis. In addition to that, if you remember in the nephron, you get absorption of sodium with potassium and chloride with the triple transporter and the ascending Weber Penley. And you also get sodium absorption with chloride with the co-transporter in the distal convoluted tubule. Because there's no chloride, sodium can't be absorbed that way. So it means that we get more sodium going to the end of the distal convoluted tubule. And instead, the sodium's reabsorbed in exchange for either hydrogen ion or potassium, once again worsening this alkalosis. So I think I'm stressing the point a lot, but just to make you aware that this hypokalemia is what, in addition to vomiting, is what's driving this alkalotic state. And that's what's really serious in these kids. We've then also got this hypokalemia that leads to intracellular shift of hydrogen ions. So normally our cells have lots of potassium. Because the potassium's low, the potassium comes out of the cells, and in exchange, hydrogen goes in. And it also leads to the activation of another channel in the kidneys, potassium and hydrogen exchanger. And once again, worsening alkalosis. Okay, I know that's quite complex. I don't think it's essential for your exams, but I think it's good to know. And it just really demonstrates the point nicely that these metabolic abnormalities are really serious, and they're what continue the alkalosis. So once again, sodium is not absorbed here, it's not absorbed here, it gets absorbed here instead in exchange for hydrogen and potassium, and thus we get a loss of potassium, loss of hydrogen, and so we become hypokalemic and alkalotic. We also get increased aldosterone, which again worsens this sodium exchange for another cation. We also then get low chloride, which affects intercalated cells, and the low potassium itself will activate another transporter here, sodium, hydrogen, potassium ATP exchange that can also cause intracellular shift. Good. So I hope that demonstrates the point nicely that these metabolic problems are quite serious. So with all that in mind, we'll go on to our second question, and that's about how we manage these patients. So remembering the case, so they've got projectile vomiting, and on examination they were quite dehydrated. So what would be the most appropriate immediate management for the patient? So would you give saline dextrose with potassium, sort of correct those abnormalities? Would you do urgent transit procedure? Would you give a bolus of fluid? Would you give some IV plasmite, or would you insert an NG tube and commence feeding? So I'll just give you a couple of seconds just to sort of think about that, think about what you think the best immediate management is. All right, so in terms of the answer, that would be C. I know this is quite a tricky question because I've harped on about all the metabolic abnormalities, but actually the first thing we need to do is we need to correct this dehydration, this shock. I think a lot of the questions in your exams, they won't be sort of simple, what's the procedure for this, what's this? It'll be about looking at a case and thinking, what's the most important thing to do? And the most important thing to do with any patient is an A2E assessment. This person's breathing, this child's breathing is fine, but when we get to C, they're tachycardic, they've got a prolonged cap refill, they've got reduced skin turgor, they've had less wet nappies, they've been more tired. We're quite worried about them in terms of their fluid status. And so it would be important to do some initial resuscitation with saline boluses. Okay, and of course you always ask for help as well. not everyone with pyloric stenosis will present like this. Some of them might not be dehydrated, and some might not even have metabolic abnormalities. But after that, you need to correct the metabolic abnormalities. And this option here, A, is the best way to do that. So you're giving fluid, which will correct dehydration, you're giving dextrose as well. And the saline will also contain chloride and vitamin G. And because you're giving chloride and you're giving potassium, it means that the kidneys can do their job and get rid of all that base, all that bicarbonate, and actually correct the alkalosis. Because it's the low chloride and the low potassium that stopped them doing that before. But if we replace it, then the kidneys can correct that alkalosis. So it's really important to correct their metabolic abnormalities. Okay. We wouldn't give plasmolite, that's got bicarbonate in it, and it's just not what we use. Instead, an energy tube is good, but what we don't want to do is we don't want to start feeding. So after we've done the metabolic abnormalities, we put an NG tube in, called a Ryle's tube, and that's to decompress the stomach. That's to get all the contents out, so we don't continue vomiting, we don't continue losing hydrogen ions. And as such, we also put them nil by mouth, because again, the vomiting, the eating is what's causing vomiting. So we've got the NG tube and the nil by mouth to stop them vomiting, to stop the initial cause of the alkalosis. And then we've got fluids to correct the already pre-existing metabolic abnormalities that are maintaining that alkalosis. And then finally, only after you've corrected the metabolic issues, then you would do pyloromyotomy, which is also called a Ramsted's procedure, and they just make a cut in the muscle of the antrum to relieve that pressure. Okay. It's important to not rush into this, because operating on someone with, deranged electrolytes is dangerous. The high bicarbonate, for example, it's sort of shown to be related to poor respiratory effort after surgery. So that's why we don't rush into the surgery. Okay, this is sort of a medical emergency rather than a surgical one. Just to summarize the message again, correct the shock, corrects the electrolytes. You can do an ultrasound to confirm the diagnosis, stop them vomiting, putting them nil by mouth and insert energy, and then and only then you can do a Ramsted's procedure. Good. So that's the first case. I know it was quite complex the way I went through it, but I hope it was sort of beneficial for you. Let's just have a break to answer any questions before we go on. If you have any, any questions at all? All right, let's move on in that case. So we're going to look at a surgical emergency now. So a bit different. So Stephen, an 8-month-old boy, he comes into Peds A&E with his parents, Molly and Gemma. He's vomited 15 times since the onset of illness 30 hours ago. Looking at the vomit, it looks quite green. The parents think he's in pain, as we talked about earlier, because he's been crying and he's been crying constantly and he keeps pulling his legs up. And they also say they've noticed fewer wet nappies, and they also think they saw some blood in the stool this morning. Interestingly, they also report some episodes of vomiting in the past, and these have resolved spontaneously. So just take a minute to kind of think about, firstly, are there any red flags and what could be going on in this case? Okay. So going through it, I'd say we'd be quite worried about them. They are dehydrated again, they've got new wet nappies, and they've got bilious vomiting. And remember, bilious vomiting means obstruction, because the obstruction has to be distal to the duodenum, because that's where bile enters the GI system. So we know there's an obstruction there, and the vomit is coming from that area of the GI tract as opposed to the stomach, where it might be something like gall. So we're quite worried about this patient. And so your differentials for intestinal obstruction, sort of higher up obstruction, would be midgut volvulus, intussusception, and duodenal atresia if they were a bit younger. So it can be quite hard to differentiate the causes, so midgut volvulus and intussusception. And to a degree, I don't think it matters, because what you need to know is that bilious vomiting is serious and it needs investigating. So whether it's midgut volvulus or intussusception, you'd still be wanting to investigate properly and treat properly. Okay. In terms, there are certain factors in the history that can lead you one way or the other. So number one, midgut volvulus tends to happen in slightly younger children. So those with malrotation, I think it's about 90% have a midgut volvulus within the first month. Intussusception can be a bit older, but it doesn't have to be. Again, as I said, it can be sort of any age, and it varies. Number two, midgut volvulus is constant pain, because it's this twisting of the intestines and a necrotic effect on the whole small intestines, leading to a chronic pain. Whereas intussusception is only pain when we have peristalsis going against that sort of telescoped portion of the bowel. Okay. And then number three, the final difference is sometimes midgut volvulus, you can have previous episodes of pain, because people with malrotation, sometimes they get twisting of the bowel and then it spontaneously untwists, and then it might twist again and then untwist. So sometimes in the history, they'll have had previous. But what we'll do now is we'll talk a little bit in detail about these two key causes of intestinal obstruction, starting with midgut volvulus and then intussusception. So a little bit of embryology. I'm really sorry, but I'm going to be quick. So the gut starts as a straight tube. We then get a bend in the tube. You can see it here. So it bends out and it herniates into the yolk sac. And that's just because the small intestines, as you know, are really, really big, so they can't develop in the abdomen. So we get herniation like that. What happens then is we get a series of rotations, and that's so we can get it from this straight tube with a bend to the formation that we're all well aware of. So firstly, the lower bit, as in the colon, will twist and come above the higher bit, so the small intestine. And that kind of makes sense, because we all know the transverse colon is at the top and it goes above the small intestine. So that's our first rotation. And then we have another rotation in which the cecum rotates 180 degrees to get it from up here in the right upper quadrant down into the right iliac fossa where it should be. Okay, so straight tube, it's bent, and we get one rotation to get the colon on top, and then another rotation to get the cecum in the right iliac fossa. And what happens in malrotation is this second rotation doesn't happen. So instead, these children have a bowel that looks a bit like this, and that leads to significant anatomical differences. And these anatomical differences are very serious and present complications, namely midgut volvulus. So normally, the small bowel is attached to the abdominal cavity via the mesentery. And the mesentery is just this sort of fold in parietal peritoneum. So it comes from the back of the abdomen and just supports the small intestines in the abdominal cavity. And the root of the mesentery, so where it folds, is between the cecum here and the duodenal-jejunal junction. So it's quite like a large fan-like structure that's supporting the small intestines, isn't it? But in the case of malrotation, we've got a couple of anatomical differences. Firstly, the cecum's not down here in the right iliac fossa, it's all the way up in here in the right upper quadrant. And secondly, the duodenal-jejunal junction here isn't high and to the left of the midline. It's quite low-lying, and it's to the right of the midline. And what that means is that the distance between the cecum and the duodenal-jejunal junction is smaller, and that means that the mesenteric root is smaller. And so instead of the small intestines being supported by this big fan-like layer of mesentery, it's just supported by this small little stalk. And because it's only supported by this small little stalk, we can get twisting. In other words, we can get midgut volvulus. And in fact, we're very, very likely to. Most people with malrotation will get midgut volvulus. There's also a second anatomical abnormality, and that's something called a lad band. So a lad band is just this fibrous bit of tissue that normally attaches the cecum here to the side of the abdominal cavity. And normally that doesn't cause any issues, it doesn't cross any structures, but because the cecum's up here in a different place, the lad band crosses the duodenum. And so that lad band, that fibrous bit of tissue from the cecum, can compress the duodenum and thus cause obstruction. Good. So we've got two anatomical abnormalities that can cause intestinal obstruction. Both a tendency to get midgut volvulus and also lad bands. So which do you think is more severe? Just have a think. Is it the obstruction due to the lad band, or is it the obstruction due to midgut volvulus? Who do you think presents more sick? Anyone want to answer? Yeah. So it's the children that have midgut volvulus over the lad band obstruction. And we'll explain why. In both, we get blockage of the bowel and we get bilious vomiting. That's fine. But in addition, in midgut volvulus, we have got twisting of the whole mesentery for the whole small intestine. And that obviously includes the venous and arterial supply. And what that means is we get venous obstruction, and so we get a buildup of fluid in the bowel wall, and we get this edematous bowel wall, and we also get poor blood supply to the bowel wall, so we become ischemic, and it becomes necrotic. And this necrotic, ischemic, edematous bowel can go on to perforate, and then those children will become septic, and they have a high likelihood of getting septic shock and all the issues that come with that. So midgut volvulus is very serious. And those with midgut volvulus, they'll often have blood in the stool because we get the sloughing of the ischemic tissue and all the components of that, leaving this bloody stool. Okay. So midgut volvulus, very serious. And the point I want to stress is this is the whole small intestine being involved. It's not like in an adult with a sigmoid volvulus, where it's just a little bit of colon. This is the entirety of the small intestine. And so if our whole small intestine becomes necrotic and we have to remove it, that's going to have, astronomical effects for that child's life. So it really is sort of a surgical emergency. Contrasting the pyloric stenosis, this is very much a surgical emergency. In some children, as I said, instead of becoming all necrotic, the bowel can just untwist back. Yeah. So some investigation. So good start with a chest X-ray, an abdominal X-ray. This is called the double bubble sign, and that's a sign we sometimes see in intestinal obstruction that's high up. And all it means is we only see gas in two places, the duodenum and the stomach. And they're both dilated, so like big bubbles. It is more fascinating with duodenal anesthesia, you can see it too. And then after you've ruled out maybe perforation, and you can sort of see some anatomical abnormalities, you're going to want to confirm that with an upper GI contrast study. So here we can see something called corkscrew sign. It looks like kind of a screw, doesn't it, as the bowel sort of twists down and it's all filled with contrast, and that's called a corkscrew sign. And even in those who don't have midgut volvulus but have malrotation, the upper GI study is still really, really good because it can show us the malposition of the duodenum. So you would see the duodenum junction being, again, to the right of the midline and low as opposed to the left of the midline. So this test is sort of the most sensitive for diagnosing malrotation. There are others. At the top with a picture of a colored duplex ultrasound scan, and you can see sort of blue venous blood twisting around the red arterial blood, representing the inferior mesenteric artery twisting around the superior mesenteric artery. And again, an ultrasound can diagnose malrotation, but less useful. And so can a barium enema. You could see the cecum in the right upper quadrant. Again, less useful. Okay. And then, as I said, this is a surgical emergency, so we need to treat them surgically as soon as possible. What you need to do is something called a LADS procedure, and this involves firstly untwisting the volvulus. You cut the LAD band and you remove the appendix, just because the cecum is going to end up in a weird place. And so we remove the appendix in case they get appendicitis later in life, and then it can be really hard to diagnose just because it's in an odd place. And then instead of putting it in the normal position, we put it in the non-rotation position. So if none of that embryological rotation had happened at all. So the cecum's down here in the left ejector fossa and the duodenum's up here. And even though it's not in the right position, the mesenteric root's still really big, isn't it? So there's a huge distance here compared to here. And that means that our chance of getting volvulus is much lower. Okay. Of course, some children, we can't do this. We need to resect some of the bowel, and so then they'll have a stoma. Good. So just another little question. So in terms of complications for surgery for midgut volvulus, which of the following is the most frequently encountered? So is it the need for a lifelong stoma? Is it recurrent midgut volvulus? Is it short bowel syndrome? Or is it colorectal carcinoma in adulthood? Or is it dumping syndrome? So just have a little think in terms of, you know, sort of the basic kind of mechanism of the disease. What is the most likely long-term complication? Cool. So in terms of an answer, it's short bowel syndrome. I remember we said it is the entire small intestine that's involved. And so I added this question just because I really want to stress how horrible it can be for these children. The whole small bowel can become necrotic, and they have to have it all removed, and they have to have lifelong TPN. So it really is sort of an emergency, and that's why when we think of bilious vomiting, we need to act quickly. Okay. Good. So we'll spend a little less time on intussusception. Let me know if you have any questions. So in intussusception, we have telescoping of a proximal bit of bowel into a distal bit. And that's often due to something called a leading edge. So a leading edge could be a lymph node, or it could be a Merkel's reticulum, and all it is something that sticks out from the bowel wall, and it gets caught up in the sort of waves of peristalsis and gets sucked into the more distal part of the bowel, leading to this telescoping. Along with the telescoping, we get the mesentery dragged in here. And that again, similarly to midgut volvulus, will lead to venous and arterial obstruction. We get the bowel wall, we get ischemia to the tissue, we get sloughing off of cells, leaving this characteristic red currant jelly stool. And then again, they can become quite unwell and perforate and become septic. Good. The pain, as I said earlier, isn't constant. It's only when we get peristalsis of the stool going up against this telescoping part of the bowel that's led to obstruction. Okay. So instead of an upper GI series, we often do an ultrasound. And I think when I was studying it, there were loads of different kind of terms for all the signs you see on an ultrasound. And all it is depends on what view we're looking at the telescoped portion. So if we look at it from a transverse point of view, what we see is we see layers of different types of tissues. So we see mucosa, submucosa, and the muscle and lumen. And that leads to something that looks like a sandwich. So we call that a sandwich sign. Because if we look at it from a cross-section view, we see some rings of tissue. And so we call that a donut or a bullseye sign. And then sometimes, if we view it with the mesentery as well, we'll get this sort of layered appearance plus a big white bit. And some people think that looks like the pelvis of a kidney. And so from a transverse view, we call that a pseudo-kidney. And from this point of view, we see a crescent of this kind of really white mesenteric tissue. It's only half a crescent, it's not the whole thing because the mesentery is only on one side of the bowel. So we call that half a crescent in donut sign. So those are the kind of signs you see at ultrasound. You see them on X-ray as well, but more so ultrasound. And in terms of management is, first line is an air or a barium enema. So what we're doing is we're pushing air into the colon, and then get here, and the idea is it pushes that telescope bit back, and it resolves the obstruction. Here we see something called meniscus sign, and that's just the telescope proximal to the bowel going into the distal bit. With this, with doing an air with barium enema, there's a risk of perforation. And if we're worried about perforation, so we think they're already perforated, we don't do this. And even in those who aren't, we want to do it in a surgical environment where we can operate quickly in case they perforate, and we want to observe them afterwards, the signs of perforation. Okay. If we are worried about perforation, instead we do surgery to just resect a part of bowel and then can do a stoma or create a joint. Okay. You'd also cover with antibiotics. Good. So we're nearly done. We've just got one short case. I think, again, they were quite tricky. If you've got any questions, you can take a break and try and answer them now. Yeah. All right. Good. So yeah, any questions, just message them. I'm starting to see some of them on the chat, it just looks blank, but we'll sort that out later. Good. So the final one is vomiting in a neonate. So the case is a 2-day-old baby girl called Sabrina is brought to Peds A&E by a dad. Dad's noticed some abdominal distension, and they've had one episode of bilious vomiting. She's feeling well, and behavior doesn't seem altered. The dad's concerned that she hasn't passed stool yet. So have a little think about differentials. So they're a neonate, they're very young. They've got abdominal distension, they've got bilious vomiting, so we're thinking maybe it's a kind of a lower down cause of obstruction. And they haven't passed stool yet, so that rings a bell. So in terms of differentials, we'd be thinking Hirschsprung's disease, firstly. Other causes could be necrotizing enterocolitis. And it could also be something like meconium ileus, something you see in cystic fibrosis, for example. And it's really hard to differentiate those causes. And again, as I said, and I keep saying, before, it doesn't really matter. But the important thing is you know that this child is quite well. They haven't passed stool, so they haven't passed meconium, and they have bilious vomiting. Okay. So what you would do is you do loss investigation. But in this case, it's Hirschsprung. So let's talk a little bit about what that is. So these are the layers of the bowel wall. You've got your mucosa, which is the middle bit. Underneath, you've got submucosa. Then you've got muscularis propria. And then you have cirrhosis or adventitia. Each of these layers have nerve flexi. So in the submucosa, you've got your submucosal plexus, which is included myasthenic plexus. And then in the muscular area, we have the myenteric plexus, bowel plexus. And what happens with the muscle in the bowel wall is we've got circular muscle, which is at rest when there's no nerve stimulation, is contracted, and that stops any stool going backwards into the proximal part of the bowel. And we've got sort of our longitudinal muscles, and these relax to allow the passage of stool forward. So when we get nervous stimulation, we get relaxation of the long muscles, allowing to move forward, and also the circular muscles, allowing stool to pass down. In Hirschsprung's disease, there's a problem with the embryological development of the enteric nervous system. So the neural crest cells that normally go on to form the enteric nervous system don't do that proportion of the bowel. And the way the nervous system for the bowel works, it starts proximally and goes all the way down. And so our aganglionic segment, the bit with no nerves, is always the most distal bit. And that can continue for a varying length. Sometimes it's just a little bit, rarely it can be the whole colon. And what that means is we have a varying length with aganglionic colon that, because there's no nerves at play, the muscles can relax, and so it's kind of permanently contracted like that. And so that means no stool can get past this contracted part, and so we present with constipation, and then we also present with, due to this kind of backlog of stool, again, bilious vomiting and also abdominal stimulation. Okay, good. So that just shows that again. We've got a ganglionic segment here, it's all contracted, and we've got a big build-up of stool in that bit there. And as I said, a ganglionic segment can be varying lengths. It can be all the way to here, it can just be a little bit like here. And that means that for Hirschsprung's disease, people can present dramatically differently. So a child can present in not passing meconium, or they may present even much older as a child even, with just sort of constipation and maybe sort of a vague history of delayed passing of meconium, for example. In terms of your investigations, you want to do an X-ray first. We can rule out perforation and we can look at different causes. So maybe duodenal atresia, things like that. And then we want to do a variant enema. So contrasting the upper GI study where we put variant down, this time we want to put variant up, and that's going to fill the colon. And here you can see really nicely this contracted aganglionic segment, and then this big dilated bit. And this bit here between the two is called a transition zone. And that's what they always look for when they do this. So just the transition of the contracted bit to the dilated bit. And then to get a good diagnosis, we do a biopsy. So you can do a full thickness or a suction biopsy. A full thickness biopsy will go through mucosa and it will go through the muscle, whereas a suction biopsy will just go to the submucosa. So which do you think's sort of better? Sort of have a little think about which would we rather do in clinical practice. So while it's the absence of the myenteric plexus that's causing a lot of the pathology, because it's the muscle that doesn't relax, the Meissner's, the submucosal plexus, is also missing. And so if the Meissner's plexus is missing, we can be pretty confident that the Albrecht plexus is missing too. And so actually it's sufficient to just take a suction biopsy. You don't need a full thickness. And the benefit of doing a suction biopsy is it means we don't have to anesthetize the child, and it can just be done much quicker and more simply, which is always good. Okay. So suction biopsy is with the gold standard to diagnose. The first thing you do is going to be an X-ray and then a variant. And there's other things you can do as well. I put some stuff in the description of the PowerPoint. I'm going to read that later. Okay. So a little question. So they've been diagnosed with Hirschsprung's and they've had surgery. They just resect the aganglionic segment. And then this child, Sabrina, she's represented a month after surgery, following the diagnosis and surgery. And then Dad said she's felt very feverish. She's had some very loose stools and she's got a distended abdomen. So which of the following is likely to represent Serena's presentation. So is it short bowel syndrome? Is it norovirus infection? Is it Hirschsprung associated enterocolitis? Is it toddler's diarrhea, or is it celiac disease? So have a little think about that. You can answer in the comments. Fine. So we'll have a look at the answer now. Oh, sorry. So the answer is Hirschsprung's associated enterocolitis. And again, I think this is a bit niche to come in your exams, but I think it's important to know about. And the reason I think it's important to know about is because it's Hirschsprung's associated enterocolitis, which is the leading cause of mortality in these patients. And it affects a lot of the way in which we manage these patients, because it can be a really devastating side effect, a complication rather. So what it is it's bacterial overgrowth in the colon. And we used to think this was due to sort of stasis of the stool. So you have this constipation, you have the stool there, and then bacteria grow as a consequence of that. But actually, the complication can happen both pre-operatively and also post-operatively. So we're leaning away from, I say we, the scientists who do this research are sort of leaning away from that kind of school of thought now. And the thought is more it's due to an error in the gut microbiome and also the primary kind of mucosal immune defense. And thus they're more likely to get this bacterial overgrowth. And what happens is they get this bacterial overgrowth and they become very unwell with fever, a distended abdomen, and diarrhea. There's certain sort of risk factors for those who get it. So pre-op, the ones that get it pre-op, they're things like, do they have Down syndrome, a delay in diagnosis, a really large aganglionic segment. And then post-op are people who had it pre-op, for example, and then also those who have obstruction for some other reason. Okay, and this is a really, really serious complication, and so it affects the way we manage patients. So first thing we do in management, as I've said, is we will always do our A to E, but then we will want to surgically remove the aganglionic segment. And then sometimes what we do, depending on if we think they're at risk of Hirschsprung's enterocolitis, we can do bowel irrigation. So that's just putting saline into the bowel through the rectum to keep it clean and stop that sort of stasis of stool and that bacterial overgrowth. Okay. And then in addition, if we're worried about that, we can give IV antibiotics too. Okay, good. So there are all our cases. We've done all the part. I know it's been quite tricky, so well done. Do we have any questions or anything at the moment? Cool. All right, so we'll go through a couple more SBAs, just to kind of consolidate what we've talked about, and then just review everything as well. So first question, a mother brings in her 1-month baby girl to the GP practice. Since birth, she has episodes of regurgitative vomiting after meals. Vomit just looks like milk. Stools have been normal. She's passed meconium within the first 24 hours of life, which is normal. And then mum does say there's been fewer wet nappies. And then we move on to examination. And there's reduced skin turgor. They've got a capillary fill of over 5 seconds. And they have a heart rate of 187 beats per minute. Got a normal range area. So looking at this patient, what is the most appropriate management? Which we advise the parents to feed the child a 30-degree angle and prescribe some food thickeners, which we give them omeprazole, which we refer for fundoplication, would we send them to A&E, or would we speak to the child safeguarding team? So I'll just give you a bit of time to think about that and come up with an answer for that. So the answer for this is you want to send them to A&E. And the reason for that is, again, you don't need to know what's going on with the patient, but you need to know that there's a red flag in this child and that they're very dehydrated and that they're tachycardic and they've got reduced skin turgor and they have a prolonged refill time. So regardless of what pathology is, they need to get some fluid resuscitation, and you can't do that at the GP, so you need to send them to it. Okay. Going through the other answers, these would all be sort of good for board, which this is. You start with service management, get them to sit up and have food thickeners, and a PPI, so that will decrease the acid in the stomach. And then fundoplication, in which they twist the fundus of the stomach around the esophagus to tighten the gastroesophageal sphincter. Is sort of much later down the line. And then vomiting can increase the risk of non-accidental injuries, but there's no sort of evidence. Okay, good. So next question. So a 7-month-old boy is brought to A&E with bilious vomiting. We do an ultrasound scan and we see a crescent in donut site. So given the most likely diagnosis, which of the following is not likely to predispose the child to this condition? So which isn't going to cause whatever condition it may be? Yeah, just have a think. Okay, good. So in terms of answer, Down syndrome. So this is a classic sort of intussusception presentation. It's a slightly older infant, contrasting with gut volvulus. They've got bilious vomiting, and we have an ultrasound that's confirmed the diagnosis pretty much with this sort of apneumotic sign. And we want to know what predisposes them to it. I don't think I told you this specifically, so don't worry if you get it wrong. Malrotation can, as well as the gut volvulus, predispose you to intussusception. I'm not sure why. I assume it's just sort of you've got a weird shaped gut, and so you're more likely to get errors in terms of how the sort of peristaltic waves transmit through that gut, and that's more likely to get intussusception. Also, being male is more common, and then a Merkel's diverticulum and can act as a leading edge. We talked about that, and then recent viral infection. So that can lead to an enlarged lymph node in the gut, and again, that can lead as act as a leading edge. Down syndrome is not associated with this, but it is with things like Hirschsprungs we've talked about, and also duodenal atresia, both of which don't present like this. Okay. Next question. So we've got an 8-week-old baby boy comes to the PEDS assessment unit because he's vomiting, it's getting worse. You ask the mum about vomiting and discover it's been increasing over the last 1 to 2 weeks. It's non-bilious, happens after every feed, and the baby's hungry for food immediately afterwards. So which of the following Paediatric gas results will help confirm most likely diagnosis? So have a look at these and think which would you expect with the likely diagnosis. A lot of numbers on there, and there might be an exam, but just go through it really systematically. I think would be my advice to just go one sort of bit at a time. So we can look at the answer now. So this is likely pyloric stenosis. Something I didn't really mention properly is that the degree of metabolic abnormalities is related to the degree of symptoms. So this child has been like this for a couple of weeks, and so we're expecting they're more likely to be dehydrated and have metabolic abnormalities than another child. Okay, So we're thinking stenosis, so we're thinking alkalosis firstly. So rule A and B. We think it's going to be a metabolic alkalosis because it's due to vomiting, not any respiratory cause. So we think the CO2 will be normal. So it's not likely to be that. And furthermore, we think the bicarb will be high. So again, it's not likely to be D. So these are the only two that are metabolic alkalosis. And then we look at our other electrolytes. Remember, we can get hyponatremia, hypokalemia, and hypochloremia. Sometimes the sodium is normal because we talked about kind of how we get a good endocrinological response to the low sodium in terms of the renin-angiotensin system. So sometimes it's corrected, but the hypokalemia is less likely to be corrected. So we're likely to have a low potassium, which is C. So C is the answer: metabolic alkalosis and hypokalemia. Remember that hypokalemia is important because that's what keeps us alkalotic. Okay. Couple more questions, we're nearly done. So 1-month-old is brought to Peds A&E with a history of bilious vomiting and constantly crying. The vomiting has since resolved and the child appears well. So you suspect the child has intestinal malrotation. Which investigation is most likely to help confirm the diagnosis? So you can do an abdominal X-ray, you can do an upper GI series, you can do a barium enema, you can do a suction biopsy, or you can do a color ultrasound Doppler. Let's give you a bit of time to think about that. Answer. Okay. So the answer would be an upper GI series. You need to pay attention when you do questions, because if it was what would you do first, you might be like, actually, I want to do an X-ray because they've had bilious vomiting and I want to rule out aprasia. And I mean, that would be the right answer in that case. But this is what's going to confirm the diagnosis. And we're not confirming the diagnosis of the volvulus because it's resolved. As I said, sometimes the volvulus untwists, it resolves spontaneously. But we're trying to diagnose malrotation. And those with malrotation, even without midgut volvulus, would have surgery because they're likely to get midgut volvulus. And the way to diagnose midgut volvulus malrotation is an upper GI variant series. You'd see the duodenal-jejunal junction, as I've said a few times, right at the midline and low, as opposed to left and middle line and high. Good. Last question. Done really well. So George is a 1-week-old child who is brought to Peds A&E with bilious vomiting and abdominal distension. They've been constipated, but otherwise seem well. There's no antenatal history, but Dad says there was a delay in George passing his first stool. So what would you do next? Would you alert the theatres, keep child nil by mouth, and get a group and save? Would you do an abdominal X-ray? Would you do a suction biopsy? Would you do a barium enema? Or would you do an abdominal ultrasound? A bit of time to think about the question and answer. The answer would be an abdominal X-ray. As I sort of said earlier, pay attention to the question. This is what you would do next. So if it was what is the best investigation for Hirschsprung, this is a very sort of classic issue, 1 week, sort of in the ENA, the bilious vomiting, and their extended abdomens with some kind of obstruction that's lower down. And they haven't passed the first stool, so we're thinking, well, it could be meconium-ileus, or it could be more commonly sort of Hirschsprung's disease. If we wanted to diagnose Hirschsprung's disease, we'd do a suction biopsy. But that's not what we do next. What we do next is we do abdominal X-ray to look to see if there's any perforation, and also better determine what the cause is, whether it's Hirschsprung's, we see that aganglionic tight segment, or is it something like meconium-ileus that you see here. Good. Well done. That is the end. What I'm going to do now is just sort of go over everything we've gone through really quickly, just to summarize. So firstly, when it comes to vomiting and peds and anything, in fact, make sure you have a system. Doesn't really matter what the system is, but I think a lot of the questions I gave you were quite complex, but I think if you have a logical system, you think, okay, at this age, the vomiting is this quality, this character, it's easier to sort of narrow down and just think what it could be. And then also remember your red flags, because again, it doesn't matter a lot of the time what the cause is. It doesn't matter if it's gore, it doesn't matter if it's pyloric stenosis. You've got a child who's unwell, you need to treat them. And that'll be a lot of the questions, I'm sure, in your exams. It won't be, what is the best treatment for this? It's what would you do in this specific scenario? And that's why you really need to know, is the child sort of well or not well? So there are your red flags: signs of obstruction, fever, abdominal pain, and then any kind of signs of dehydration. In terms of pyloric stenosis, remember it's a medical problem. Lots of weird electrolyte stuff we've talked about. Even if you don't know exact cause, manage them on the acutely unwell patient with fluid boluses. They have metabolic alkalosis, which is maintained by hypochloremia and hypokalemia. And to correct the metabolic alkalosis, we need to, as such, replace the chloride and replace the potassium. Okay, and that's before any kind of surgical intervention. And then for malrotation, so mid-gut bolus is a surgical emergency because we can get necrosis all the small intestine, and they need an upper GI series to diagnose because we can see the displaced duodenal junction, and they need a LADS procedure. And then for interception, so our first line management is enema. Don't do it if there's a risk of perforation or if we think they're perforated. And there's lots of different ultrasound signs. I think when I was studying, it initially really confused me. Just got to remember, it just depends on what you were looking at the telescope about. And then Hirschsprung's disease, it can affect a varying length of colon, and thus it can lead to various presentations. You need to not know a great deal, but you need to be aware of Hirschsprung-associated enterocolitis, because that's what sort of kills children with this presentation. And you need to diagnose. You could do a suction biopsy, and that's just as good as a full thickness, in fact better. And then finally, try not to stress too much. I know you guys don't have your exam soon, but I'm sure you'll all be fine. All the stuff we went through today, I think, was quite challenging, and I hope it pushed you, and I hope you learned some things. But yeah, don't let it stress you. Don't worry about what everyone else is doing. I'm sure you will all do fine. With that, good luck with your exams. If you have any questions, please put them in the chat or the Q&A bit, and we can go through them. I'm going to leave this up here, so if you can all just do some feedback, that would be really useful for me. I really appreciate that. And then, we can go through any questions you guys might have. I'm struggling to sort of see them on the chat. So if you can do them on the Q&A bit, I can answer them there. So we'll just go through them there, and then while you do that. So do intestinal malrotation volvulus have the same presentation? Okay, so intestinal malrotation is asymptomatic. All it is it means the gut's not in the right place. So our cecum's up here, and as is the duodenum. It doesn't cause symptoms. Intestinal malrotation is dangerous because it causes volvulus, and volvulus is the way they present. So in terms of management, in terms of investigations, it'd be similar, because again, you want to rule out perforation, and the best investigation for malrotation is an upper GI series. And then the management, again, they need surgery, because if you've got malrotation might be asymptomatic, but it can cause mid-gut volvulus, and so you need to treat them surgically. So they'll have a LADS procedure. The difference might be if they've got mid-gut volvulus, by that point, maybe they've got lots of ischemic bowel already, and you need to resect some. Okay, I think that answers that. Let me know if it doesn't, though. Okay. Um, yeah. So with these sort of questions, it's really hard sometimes to know what you would do first. I think generally what you're worried about in these patients is perforation. That's the same for any kind of obstruction. And you can't really see perforation on ultrasound as well. And so I know there's radiation. That's very valid. And of course, if your PEDS consultant says otherwise, I'd go with them, absolutely. But my kind of reasoning would be, you're worried about this patient acutely. I think one dose of an X-ray is a lesser evil than letting them perforate and become septic. But yeah, that's good. And I like how you're sort of thinking about it in terms of how you could approach it differently. And of course, like in real life, I'm sure some people do set investigations for others. But you just seem to be sort of happy with how you do it. Yeah, keep the questions coming for more. Couldn't you alert theatres get a blood sample and keep the nil by mouth or wait for an X-ray? Yeah, of course you could, but you don't know what the diagnosis is, firstly. So if you worried about perforation, more so, maybe you would alert theatres and then get an X-ray. I think the last question was quite a tricky one. I was doing it, saying it's a thing. Lots of people, but what I would say is that if it's just Hirschsprungs, you don't need to operate right then and now unless they've got a perforation. And so I think it's more important to get an X-ray to see if they've got a perforation, to see if they need that kind of urgent surgery. If they don't have the perforation, you don't need to do urgent surgery, so you don't need to pull out the theatres straight away. You can instead take your time a little bit more. You can get like a barium and a suction biopsy. Okay, good. If there's any more questions at all, just pop them in the Q&A bit. And there's lots of technical difficulties. Oh, thank you. But yeah, any other questions? Otherwise, I think we can leave it there. Good job. It's been quite some tricky stuff. I'll just leave it for a little bit longer in case anyone else wants to do any kind of feedback or ask any other last questions. That's fine. I'm not in a rush because it's lockdown. So feel free to answer anything or anything like PEDS related we can go over. That's fine. Okay, great. Thank you so much for listening, everyone. Best of luck with all your exams. I'm sure you'll all do great. I'm so for the history.